I'm
please.
H.S. Kim from SNU Hospital. My co-operator is Dr. Jiun Kang and Yoo-jung Kim, and Kim Young-min, Kim Dong-guk, two specialists from Edwards Life Science to help us, and Kim Jae, nurse, okay. From now on, I'd like to present the third live TAVI of SAPIEN. Slide, please. An 83-year-old male underwent CAG for atypical chest pain 4 years ago, which revealed his insignificant lesion at LCX and RCA. At that time, he has been treated under diagnosis of moderate AS. But recently, he has suffered from aggravating chest pain since 3 months ago, and AS progressed to severe. Plus, comorbid condition was minimal. No diabetes, no renal failure. 83-year-old male with body mass index 23. Plus, medication, simple. Target is severe AS using TAVI, using SAPIEN valve. Risk score is 2%, low surgical risk. Plus, X-ray normal, EKG is significant, RBBB. Thus, I chose SAPIEN valve. Plus, echo show normal function, ejection fraction 58, no volume motion abnormality. Mean gradient is about 50 tall with variated just 1 square centimeter. Plus, angiogram show the mild lesion at distal RCA, but today it progressed significantly, FFR less than 70%. Thus, we put stent. Plus, aorta good, few calcification. Angle is good, no horizontal aorta. Plus, valve calcification is not much, balanced. No calcification at annulus nor LVOT. Size is about 26. It's very safe, simple, not malignant case. Plus, sinus valsalva wide enough, 34, 34, 36. Acid junction wide enough, 31. It's minimal calcification. Plus, acid junction height is tall enough, more than 22. It should be at least more than 18 millimeters to avoid touch between proximal frame of SAPIEN valve to acid junction. Thus, acid junction height is a little bit important when you do SAPIEN valve. Coronary height is wide, tall enough. Plus, iliofemoral artery, good, wide, no calcification. Plus, left also good. Plus, to summarize, annulus 25, perimeter 80, area 480, height of acid junction good, calcification at acid junction minimal, acid junction is bigger than annulus, LVOT is similar to annulus, coronary height is tall, sinus valsalva, acid junction wide enough, aorta normal. Plus, perimeter area is about 480. That corresponds to 26 millimeter valve with 8% oversizing under nominal inflation. Thus, I'd like to do just 0.5 cc over inflation to meet about 10% oversizing. Plus, in the presence of RBBB, I don't like Evolut Pro. But when you choose Evolut Pro 29 millimeter valve, oversizing is about 16%. It is good. Plus, Lotus Edge 25, oversizing is good. Plus, thus I chose SAPIEN valve because of complete RBBB to avoid complete AV block or pacemaker implantation. I prepared 2 issues. The first is octogenarian male with low surgical risk and conduction disturbance. Plus, we can see the expanding indication for TAVI on the left side. So we can do TAVI even patients with low surgical risk. Partner 3 and Evolute low risk are two landmark RCT to compare TAVR and SAVR in patients with low surgical risk. TAVR was better than SAVR in terms of composite primary endpoint on the left, with SAPIEN on the right with Evolute. Thus, we can do TAVI with low surgical risk patients. Plus, the conduction disturbance issue is shown here. Most important predictor of complete AV block or pacemaker implantation after TAVI are existence of RBBB and core valve, then SAPIEN. On the right panel, you can see the average percentage of pacemaker implantation rate is lowest with SAPIEN, then Evolute and the Lotus. Plus, this is our experience. This slide shows the importance of ECG finding, suggesting RBBB or first degree AV block. In those cohorts, pacemaker implantation rate is very high, 25%. But control conditions, pacemaker implantation rate is just 10%. Thus, I always tell my junior faculties, pre-existing ECG finding is very important factor for us to determine, to select valve type among 3 available ones. Okay, that's my presentation. And can you see the double tracing pressure?
Yes.
We punctured and introduced left ventricle aorta 2 catheters. Thus, you can see the pressure profiles of 2 chambers. Once again, flushing. Yeah. The pressure profile is just. We can show you the pressure profiles of double chamber. 0. 됐어요? Okay? Okay. We flushed pressure line once again. LV maximum pressure is about 160, aorta 130. Okay, from now on, we are going to continue the procedure of TAVI with SAPIEN 3. Okay.
How can you decide oversizing percent? What thing do you consider? What is
The company calculate, with SAPIEN valve, we measure the area of native annulus and determined valve. In Evolute, perimeter based. 어떻게 할래? 0.5cc overfill? Okay. Then what's the oversize index? 10%. Okay. So wire stay. 혈압이 좀 낮나? 괜찮나? Okay. This.
In this
Then
case, you don't
I,
need any pre-balloon. You don't need any pre-balloon dilatation.
Yeah, valve area is just 1 square centimeter.
Okay.
There is absolute no need of pre-ballooning. In
Yes.
Korean TAVI registry, we compare the stroke rate between bicuspid and the tricuspid. The higher incidence of stroke in bicuspid patients probably because of a huge calcific tissue, but most important factor is frequent ballooning. Most of the bicuspid patients underwent pre-ballooning. So my personal belief is less touch would be better, especially in terms of stroke.
I agree
Okay,
with you.
I will prepare the device. Okay. I move the valve on the balloon segment. A little bit cranial. Okay. That's LAO. So I advanced the whole system through aortic arch. 좀 보여줘야지. Wire, stay. Okay, best angle. Wire, gives a little bit tension. Okay. So I advanced the valve. Testing. Then I retrieved the pushing catheter. 환자 꽤 움직이네. Okay, close. Testing. 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 I think the position is good.
Yes, I think it is the catheter location is very center of the annulus. It's good.
Testing. Okay. 자, rapid pacing. Die. Okay, inflation.
Inflation,
Half,
half,
4,
full,
1, 2, 3, 4, 5. Deflation.
deflation,
Pacing up. 캡처가 뭐 이상하네. Okay. Wire stay. 저장. 오케이. 에코는 pressure profile is good. So, okay, echo, TTE, because of patients on the MAC, so we cannot introduce TEE. TTE, finding,
We cannot see the significant AR in here.
okay. How about cross-section?
Except the wiring side, yeah, everything seems to be okay.
Okay. Then we can do angiogram with wire in situ. Because if there is a huge regurgitation parabola, we can do post-ballooning. Okay. 스네 준비. 스네. That probably due to the transvalvular regurgitation by a stiff wire. So we like to change the stiff wire with a pigtail catheter. Wires 2. Y stay.
Okay.
Y stay. Okay. So pressure 0. We always repeat the zeroing process for accurate measurement of pressure. Okay? 프레셔 좀 낮춰주세요. Pressure gradient disappeared, and it is very high, about 180. So I request my doctor to reduce blood pressure. Because when we calculate AR index or knew our dichrotic notch AR index, the baseline blood pressure is very important. Thus, we always adjust the systolic blood pressure as the systolic blood pressure before TAVI. Okay, now blood pressure down to 150, 140. 이태민 선생님, 아까 그 우리 AR 인덱스 슬라이드 한 개 띄워 보실래요? Okay, slide. Can you see our slide? 방송.
No.
지금은 헤모다이님은 보이는데.
Yeah, okay.
We can see the.
Okay.
Okay, now we see.
Okay. This slide shows we developed a new dichrotic notch AR index that is published in this year JAG intervention. Traditional AR index is B/A, B/A. But when we do ROC curve analysis, the prediction power of significant leakage with traditional AR index is just 6%. It's very low. On the right panel, 25 is cutoff value to assess good or bad, but even it is more than 25, still there is about 10% of significant leakage. So predictive power is limited. Thus, we try to seek another useful parameter index that should be simple, reproducible, more accurate than traditional. Among several parameters, we determined C/D is most effective parameter. Thus, we named it a new dichrotic AR index. Cutoff value is 3 and 4. Above 4, no leakage. Less than 3, moderate leakage. Between, mild leakage. The predict power on the ROC curve analysis is about 80%. Definitely better than traditional index. Cutoff value is 3.3. When AR index is greater than 3.3, the significant leakage chance is very low, about 3%. While it is less than 3.3, leakage percentage is about 30%. We try to check again in this case. Okay, previous slide. Hemodynamics, slide change, hemodynamics로. 헤모다이내믹 커브 보여줘야지. 슬라이드 올리고. Now the blood pressure normalized, so you try to calculate the new AR index to avoid premature beat by slightly retrieval of LV pigtail catheter. Okay, systolic blood pressure is 120, 120, diastolic notch 85, diastolic 6, LVEDP about 23. 적었어?
60, 60.
Another call is 120, 80, 52, 20. Traditional AR index is about 25 to 30. New dichrotic AR index is also 3.9, 3.6, 4. Both index support the leakage would be minimal. Okay, let's check the angiogram. First, I'd like to do angio with LV catheter in situ. Okay, 쓰네. Minimal leakage. So I retrieve the LV catheter. Then another angle, this angle once again. Oh, minimal leakage. Because the patient profile calcium grade is very little, thus we expect such kind of results. And please see the just gap between SC junction and uppermost valve frame of sapien. The SC junction height is about 22, but when we deploy the sapien valve very high position, it may nearly touch SC junction. But in this case, even though SC junction is lower and touched by frame, there is no calcification, a subtle calcification. Diameter is bigger than annulus. Thus, it is very safe situation. But as the junction is lower, narrower, and calcified, uppermost frame of sapien may touch and tear as the junction. That lead to aortic dissection. Is there any comment, question?
Congratulations.
Can I have one question?
Yes, please.
This is Dr. Bae.
Even though there, yeah.
Oh, go ahead. Go ahead.
Okay. Can you see the ECG? As you can see, the ECG, baseline ECG was complete RBBB. Thus, I chose sapien. There is no change of baseline ECG. That's the beauty of sapien valve. Thus, I always choose sapien in patients with RBBB, unless other definite kind of indications, such as a TAVI. In that case, I choose Evolut. But most of the case with RBBB, I choose sapien valve.
Dr. Kim?
Yeah.
Yeah, congratulations. It's very wonderful, nice case. But the new AR index is best predict compared to the previous AR index. Do you think what component? We know the component. Do you explain why you AR index is better than AR index to predict future? current
Yeah,
PVL.
the main difference between traditional and the new AR index is we employ the dichrotic notch blood pressure because, traditional index just B over A. So they don't estimate the real regurgitant duration that happens after dichrotic notch. So actually, D segment represents actual regurgitation. That is basis our pursuit to develop a new index. Of course, we developed other index, but dichrotic notch AR index was the best because we employed real actual diastolic parameter in there. Here, this case, new AR index about 4, traditional AR index 26. Thus, no or trivial regurgitation. That is more similar to the new, okay.
Dr. Kim, can I have
Just
one
if,
question about?
Yeah, please.
Can I have one question about the procedure for bicuspid aortic valve? As you mentioned, the bicuspid aortic valves usually have shown that the higher strong rate compared to the tricuspid valve stenosis. And so you mentioned that, the frequent touching the valve area, for example, the ballooning can make a worse prognosis in the neurology. But sometimes we can confront the severe chunk calcification in the bicuspid valve and very fibrotic area. But to overcome, sometimes we should do the pre-ballooning prior to the valve implantation.
Yeah,
And so
of course.
how can you mitigate this kind of dilemma?
My personal indication of pre-ballooning is two situations. The first one is valve area is less than 0.5 square centimeters. So we need just ballooning for the easy passage of the valve system. And especially in Lotus, post-ballooning is not permitted because of the safety issue. Thus, in case of Lotus, pre-ballooning may be more important to prepare the annulus than just put the self-expandable Lotus valve. The second situation for ballooning is ambiguous annulus size, valve area size in bicuspid AS patients. We can select a bigger valve or a smaller valve. It is very ambiguous. In that case, we perform appropriate sized balloon before TAVI and injection of dye. Dye leaked, then we choose bigger valve. The balloon is very tightly closed, the annulus, then we choose smaller valve. Thus, in such kind of ambiguous annulus size, especially in bicuspid AS, then we perform pre-ballooning for accurate sizing purpose. In other case, I don't do pre-ballooning. There are several factors to explain higher stroke rate after TAVI in bicuspid than tricuspid. The first is more touch. The second is more dirty tissue around the annulus. The third is usually age is younger in bicuspid than tricuspid. Thus, we can assess more definitely the change of neurologic symptom and sign, because younger patients are more, symptoms are more vivid and clear than elderly people. So I expect those three factors all explain the higher incidence of stroke in bicuspid.
I have one question for Dr. Kim.
Yes.
Yes.
Please. Go.
My name is Ik-sung Jo, and first, congratulations for the wonderful procedure. Because you've measured all the LV and diastolic pressure for all patients. This patient, the LV EDP is 20, is I think elevated. And so in your experience, after TAVR, usually the LV EDP is decreased after TAVR or it's kind of sustained. And also, have you ever had chance to find any prognostic relationship between the LV EDP change and the prognosis?
During short period of TAVI procedure, in my experience, there is no definite change before and after TAVI in terms of LVEDP. Now, this patient is about 20. We very frequently observe the patients with 40 or 30. After TAVI, it does not decrease because during procedure, we put the fluid. Thus, conversely, LVEDP may a little bit rise during procedure, but my impression is there is no acute short-term change of LVEDP before and after TAVI. I don't know the prognostic impact of LVEDP, but it may be related with prognosis because LVEDP reflects the LV compliance or LV function. Thus, the higher, the worse. Thus, I think it is not related to TAVI procedure. LVEDP and prognosis is also well applied in patients with TAVI.
Thank you.
Dr. Kim, can I have one more question about MAC?
MAC.
Recently, the experienced center and experienced operator usually want to do MAC. They don't want to more the general anesthesia, but there are several advantages of MAC, but sometimes we're gonna lose the precise visualization using TE procedures under MAC. And so didn't have any trouble without TE during procedures after using MAC?
I don't have any experience of bad case, especially worsened after without backup of TE. But I saw one live case in Kobe Live, CCT. The live transmission was from France, and they do MAC, and they just use TT, a very poor quality. During epidural implantation, they talk too much while blood pressure decline. So I was really afraid as an audience. Finally, arrest. Then they don't know the exact mechanism. So some panels suggest cardiac tamponade, some suggest the valve without any surveillance of TEE. So they just remove the drape and TT. It takes time, and then finally there is heartbeat. ECG blip was there, but there is no contraction, electromechanical dissociation, and death. But they lost very important critical period of time while doing remove of drape and TT, and they don't exactly assess the reason why there is a pressure drop. There is no problem, no hemopericardium, no problem. Just the patient's status was very critical, but they put in the Evolut Pro and talk too much, not deployed. So that predisposed. So at that point, if they use TE, there's no abnormality in heart, just put the inotropics and rapid deployment valve. That was the answer, but they lost the patient. So I think TE guidance is very helpful in very critical patients, but most of the patients are not so critical. Thus, in our case, there are two situations. We strongly use general anesthesia and TE. The first one is really critical case, requiring real-time surveillance with TE, then general anesthesia. The second case is intubation situation is very difficult, short neck. Then if the patient situation is worsens, we have to do emergent intubation. But when it is difficult, the patient condition became critical. Thus, in such kind hostile neck anatomy for intubation, then we do prophylactic intubation and general anesthesia, unless we do local anesthesia on the MAC.
I'm Dr. Na. Do you have any patients, especially who are younger, to discuss about pacemaker after TAVI? And some nowadays relatively young patients have some information about TAVI processes. SAPIEN makes less than comfortable blood, and the COBEL can make some more comfortable blood. And some patients wanted to take I would like to take SAPIEN. Do you have any patients like that? Patients who
I
wanted to
have
take
a
SAPIEN.
few patients with their age 60s, about 65
Yes.
years old or 67 years old. There is a specific reason why I have to do TAVI for that relatively younger patient. They expect near future kidney transplantation. Thus, they try to avoid transfusion, allogenic transfusion, because that make autoantibody against other persons that may reduce success rate or long-term survival rate of transplanted kidney. Thus, in that case, I perform TAVI without any blood transfusion. In such a case, we have to consider several factors because the patient's longevity is very long. Thus, the patients may need future coronary intervention. Thus, in that case, I prefer SAPIEN valve, which favors coronary access in the future. But the limitation of SAPIEN is narrow effective orifice area. EOA is very important factor to determine longevity of TAVI valve. The wider, the longer. The narrower, the shorter longevity. In this case, in this situation, as you can see the slide, SAPIEN is the worst choice. So if the annulus size is big, the patient, then why not SAPIEN? But annulus size is very narrow, then we can consider Evolut R or Evolut Pro. Even though there is a future difficulty in coronary access, if the patient does not have any coronary lesion, then small annulus, then we can consider Evolut.
What is your antiplatelet treatment strategy after TAVI? In ESC, popular TAVI, they recommend or they conclude aspirin monotherapy is better than aspirin and clopidogrel.
Yeah, popular TAVI is really bad, underpowered study. Their conclusion, their primary endpoint is bleeding. Just of course, DAPT has a higher bleeding rate than aspirin monotherapy. So no, it is common sense. And 1 year follow-up rate, 1 year follow-up, just bleeding is nonsense because in my experience, when we perform annual CT, aortic CT, to assess HALT, hypoattenuating left leg thickening, or a minor thrombus around the device, there is no difference of pressure gradient. So echo no abnormality in echo. But there is a not so rare, relatively frequent instance of minor thrombus or halt. That is totally subclinical, asymptomatic. But I believe such kind of minor deposition of fibrin or thrombus may shorten the longevity of valve leaflet. Thus, I'm really eager to maintain DAPT. Or if the patient has a minor indication of anticoagulant, I willingly add anticoagulant on the top of clopidogrel. Thus, my personal belief is the stronger antiplatelet or antithrombotic therapy may guarantee longer longevity of valve. Thus, if patients perfectly tolerable for medication, I recommend you stronger regimen. Just 1 year follow-up, nonsense. Longevity effect, we have to wait for 5, 10 years. 1 year, no difference. That's 1 year bleeding, totally nonsense. Thus, I don't take any message from popular TAVI, RCT. So I recommend you DAPT, or if oral anticoagulant indication is there, anticoagulant plus clopidogrel, indefinitely, if patient permits.